Good afternoon, everyone. Thank you all for joining us for our monthly series for Suncloud Health's Child and Adolescent Development Series. My name is Christy Orr. I'm a member of the outreach team here at Suncloud. My focus is on adolescent outreach. For those who are not familiar with us, we provide integrated person-centered treatment with PHP and IOP programs for adolescents and residential PHP and IOP programs for adults in the Chicagoland area, with a special emphasis on helping those who are struggling with complex co-occurring disorders. I'm also excited to announce we're launching Sunny Days. It's an 8-week virtual IOP program designed specifically for families and adolescents who need additional flexibility during the summer months where kids can attend from home. If you're interested in learning more or collaborating with our team, my contact information will be listed at the end of our event today, and I'll be happy to help. You will also receive an email with follow-up instructions on how to receive your CE certificate. Please note, in order to receive your certificate, please plan to attend the entire presentation. Once our presentation starts, feel free to put your questions in the chat, and we'll save about 10 to 15 minutes at the end for Q&A. Our goal is to support you all as community partners with monthly educational events to support your practice. Today's speaker is Dr. Patrick McGrath. Dr. McGrath currently serves as the Chief Clinical Officer for NOCD, leading their teletherapy services across the United States to help people with OCD and related disorders. He is also a consulting lead psychologist at Ascension, Illinois Alexian Brothers, where he opened intensive outpatient, partial hospitalization, and residential treatment programs for anxiety disorders, OCD, and PTSD. He is the author of Don't Try Harder, Try Different, and the OCD Answer Book. He is a member of the scientific and clinical advisory boards of the International OCD Foundation. He is also a fellow of the Association for Behavioral and Cognitive Therapies. And with that, I'll let Dr. McGrath take it away. Thank you.
Thank you. Good to be here with all of you. I'm going to share my screen and we'll get going here. So, all right, there we are. So just a little bit again on where I'm at NOCD. We're an online platform for the treatment of obsessive compulsive disorder. So if you're interested in getting more information, you can go to nocd.com. Be happy to help you out with learning about what we do there. All right. I always give a little bit of a warning when I do talks, little disclaimers that we're going to use some examples that you may not like. And I say that because some of our examples are around obsessive compulsive disorder. And obsessive compulsive disorder does not care if you're offended. It does not care if you don't like it, because it doesn't have anyone's best interest at heart but its own self. So just keep that in mind as we're going through today. Now, our focus today is going to be on the role of safety-seeking behaviors in mental health conditions. And we'll focus that a good amount on the anxiety spectrum of things. And if you think of a very basic model, you have a fear stimulus, and then that leads to some kind of misinterpretation of a threat. We read into that as being bad, awful, horrible, dangerous, something of that nature. And so we feel uncomfortable. We might feel anxious. We could be stressed. We might have shame or guilt or disgust or some other kind of discomfort. And so what do we do in that situation? Well, we try to feel as good as we possibly can, as quickly as we possibly can. And so that's where the safety behavior comes in. And when we do the safety behavior, what do we learn? Nothing bad happened. Or I only made it through because of the safety behavior. And therefore, we don't have a corrective experience. We don't learn that we could handle the thing that we are afraid of. What do we learn? I need to keep doing safety behaviors in order for things to be okay. Now, families do a lot of safety behaviors. Individuals do their own safety behaviors. And unfortunately, sometimes therapists even teach people to do safety behaviors as well, too. And I want to, hopefully by the end of this talk today, motivate you to think about eliminating safety behaviors from the work that you do instead of providing safety behaviors to those that you are working with. For 25 years now, I have been using exposure and response prevention therapy as a way to treat OCD, anxiety, trauma. And in 24 of those 25 years, I have not taught anyone a safety behavior. I have not taught anyone diaphragmatic breathing or muscle relaxation, or to replace a thought you don't like with a thought that you do, or something of that nature. And I know that there's still a lot of people who are doing those types of things. And so my goal today is to kind of make the case as to why that might not be something that you want to do anymore, why you might want to go in a different route. And please feel free to put questions into the Q&A or into the chat. And what I will do is when we get toward the end, I'll be happy to go over some of those and address some of those, and maybe we can have a good discussion on some of those things. If you're looking at how things are maintained, here is an OCD example of that model. If I had intrusive thoughts about harming a child, and I thought that having those thoughts will make me harm my child, which is something that we call thought-action fusion. Thoughts are equal to an action. Thoughts are as bad as an action. Thinking something is as bad as doing something. I'm going to be uncomfortable. And so I'm going to be refusing to be near my child without another adult present, because just in case I do have this sudden urge to harm my child, maybe that other adult could stop me. I will avoid all sharp objects around my child so that I don't inadvertently slice my child's hand off or something of that nature. I'm going to ask my wife for constant reassurance and want her to tell me, no, hon, you're a good father. You don't worry about it. You're not going to hurt our child. And every time I have a quote unquote bad thought about our child, I'm going to try to replace that with a good thought, with this notion, therefore, that there is such a thing as a good or a bad thought. And therefore, there's thoughts I shouldn't have, and there's thoughts that I should have. And when I do all those things, my child is alive. And so what do I learn? The only reason my child is safe is because I've done all of those safety behaviors. I have done all of these things, and it has maintained the balance in my home. And what am I going to keep doing? I'm going to keep doing more safety behaviors. And what am I going to learn? My child is still alive because I do more safety behaviors. And you start this hamster wheel of hell going around and around and around and around. And it gets to a point where people get so stuck in doing the safety behaviors that that becomes their life. Now, this is why people with, say, OCD do hours and hours of compulsions a day. This is why people with panic use so much avoidance, and even to the point of agoraphobia, where their life gets smaller and smaller and smaller, and they only get to a point where they might just want to stay in their bedroom and only use the bedroom or the bathroom, and they don't want to leave anywhere else. This is why people with social anxiety disorder use a lot of alcohol whenever they have to go into social situations. They want all of these things to try to eliminate any uncomfortable feelings or sensations. I would contend nothing could be worse for you than doing that. And if you truly want to get better and be able to function day to day, it isn't about providing more safety behaviors to people. It is about eliminating all safety behaviors and having people learn that they can handle things. I have not said to a patient in over 25 years, you'll be fine and everything will be okay. What I tell people is you can handle it. You may not like it. It may not be comfortable, but I truly believe you'll be able to handle whatever it is. And so that's where we really want to go in this situation, is we want to teach people that they can handle the things that are uncomfortable. So life looks a lot like this when you're anxious, right? You have this up and down kind of thing. The anxiety, the tension, whatever it is goes up. We do a safety behavior. There's a quick drop, but then it comes back again. We do a safety behavior. There's a drop. We see this up and down and up and down and up and down kind of experience. And people are stuck on this very uncomfortable roller coaster in front of us here. And yet, this is what we'd love to see happen. I'd like to see that anxiety go up and then have people just stay in the experience, allow for it to be there, and do nothing to try to make it go away. Just allow yourself to learn that you can handle the uncomfortable experience or sensation. And then do it again, and then do it again, and do it again, and again, and again, and again, and again, and again, and again, until you get to that bottom one where it's barely anything. So you'd like to see two things happen. The spike of the anxiety decreases over time, and the length of the duration of time to recover decreases over time as well, too. This is your basic habituation model, and I'd say for 95% of people, this will work well. For the other 5%, there are people who will stay anxious about things forever. And in the past decades, we would have thought that that was a treatment failure. Now there's more of even kind of an updated model called inhibitory learning, where the notion is that as I learn a new behavior, it will interfere with the occurrence of the old behavior. So therefore, if the new behavior is to become comfortable with being uncomfortable, and the old behavior was to do safety behaviors, the more that I practice being comfortable with being uncomfortable, the better I'll be over time, and the harder it will be to do the safety behaviors. Now, none of you have a head that looks like this. I just can't draw very well. But one of the reasons that I really do like to talk about this with people is that for folks who do a very general talk therapy, especially for people who have OCD or anxiety issues, you may be frustrated at times because you just don't necessarily see a lot of behavioral change, right? And one thing that could happen is that if you think about the way the brain is structured, that level 3 area, the cortex area, that's where language occurs. The problem, of course, is level 2 area, midbrain, that's where anxiety occurs. And the level 2 midbrain area of the brain has no language ability, which means it is impossible to talk somebody out of being afraid of something because we weren't even designed to be able to be talked out of being afraid. Why not focus a treatment then on the part of the brain where the problem is actually occurring? And it turns out you don't talk people out of being anxious, but you can definitely behave people out of being anxious. And so our goal is really to have people with a hierarchy build up to doing more and more things. So we're going to do good behavioral treatment, exposure and response prevention therapy. In OCD, we're targeting those thoughts, those images, those urges. In panic and agoraphobia, we're going to target avoidance behaviors. We may target substance use in social anxiety. In trauma, we're going to have people learn that they can handle their memories, that they don't need to be afraid of those. This is not to torture people, right? This is to allow for new learning to occur. I'd contend what tortures people is safety behaviors. That's what actually tortures people. And the reason that I believe that is because it's safety behaviors that keep people stuck. If safety behaviors were actually helpful, people with OCD would be amazingly healthy. They'd have no problems whatsoever because they spend so much time doing safety behaviors. But we don't see that happening. We see the opposite happening. The more they do compulsions, the more they do safety behaviors, the harder it is for them to get out of OCD. The more that you avoid things, the harder it is to live your life. The more that you shut yourself out from everyone, the harder it is to be social. So if safety behaviors worked, I'd be all over them. I'd be providing them to everybody. But they don't work. They actually get in the way, and they're the problem. And so once fear is triggered, you have a couple of options. Do you do a compulsion or another safety behavior, or do you do response prevention? And I want to always push for people to do response prevention. And what is response prevention? Very simply, the elimination of the typical response. And what's the typical response? Safety-seeking behaviors. So basically, exposing people to things that are uncomfortable and having them not do safety-seeking behaviors, that's exactly what exposure and response prevention is. So we want to replace this with belief change or habituation. You want to see people recognizing that, yes, I feel this way about that thing, but I don't really have to be all that afraid of it, right? I'm not actually in danger from this thing. It's uncomfortable. I will say that. It is definitely uncomfortable. But just because it's uncomfortable doesn't mean that it's dangerous, right? And when we learn that our feared consequences don't actually happen, or if they do, that we can handle them far better than we ever gave ourselves credit for, then we learn, okay, I can actually make it through the day without having to do all these safety behaviors. Wouldn't it be great if I had a fear of contamination and I didn't spend 6 hours a day washing my hands, right? My goal in treatment in all of this is not to eliminate whatever the intrusive thought or image or urge is. I can't go around eliminating all the things people fear, right? But what I can do is I can help people learn that they can handle their fears in a better way, right? If you're afraid of elevators, I don't go and screw the elevator to the wall so that you won't be afraid of the elevator anymore. I have to get you on an elevator and riding an elevator and teach you that you can handle it. Now, you may say, well, then let's provide all sorts of safety behaviors. So every time you get on an elevator, you've got a phone, you've got a water bottle that holds at least 98 ounces of water because who knows, you could get stuck in there and you wouldn't want to dehydrate. You could bring in maybe an oxygen canister just in case the elevator hermetically seals and there's no more oxygen allowed in. You could bring a buddy with you. You could bring a sleeping bag so that you can be comfortable if you do need to lay down. And you could bring all sorts of other things to set up in there. Or you could ride the elevator, right? And I'd contend that a lot of therapists push more safety behavior work than they do getting people to face their fears. And so, again, I'm hoping today it's motivating to think about how can we get people to face their fears. Now, I do this in a hierarchy. I do not throw people in the deep end of the pool and tell them to sink or swim. We're going to put a toe in the water and we're going to see how it feels. And we're going to build from there. And we're going to have people face those fears and learn that they can handle the things that are uncomfortable slowly, gradually, on their time frame. I don't force anyone to do things. I've never made anyone do an ERP exercise whatsoever. I'm going to get people to list for me all the things that they want to work on. We're going to rank order those things, and we're going to gradually work our way up to doing those things. So that's really what we want to see happen. So I want to just kind of dispel the myth that ERP is flooding. That is not the case at all. Flooding is flooding. ERP is a very different experience. So let's talk about some of the most basic safety-seeking behaviors that we see and that we would really want to have people eliminate. And the first one is avoidance. So if you have a misappraisal of a threat and you think that if I just avoid that thing, then I won't be in any danger, you will probably get that result. You will avoid it. You won't feel as if you're in any danger. But what will also happen is you will not get adequate exposure to the fear stimulus. You won't learn that you can handle the thing. You will learn that you are safe because you avoided it. So for those of you who are in the Chicago area, you know we have an amusement park called Great America. And you may go with one of your friends one time and you may say to them as you're walking out, I'll tell you what, it's a good thing I didn't ride any roller coasters or I probably would have died. And your friend looks at you and says, what are you talking about? There were no ambulances here today. There were no fire trucks. Nobody died here today. And your reply could be, well, yeah, but had I gotten on the roller coaster, that's probably what would have happened. So like I said, it's a good thing that we avoided all the roller coasters and we didn't ride any of them. So now what have I learned? If I want to stay safe, if I want to stay alive, it's best for me to avoid riding any roller coasters. And that can go for so many things, right? I could avoid going to stores. I could avoid driving. I could avoid public transportation. I could avoid social situations, and I'm going to attribute the fact that I'm okay because I avoided things. I don't think any of us agree that avoidance is a good thing and that we want to help people avoid more things. We want people to get out there in the world and to live their life. We want people facing the things that are difficult. You may know people who every time there's a all-staff meeting at work is the day they call in sick, right? Because they don't want to be called on in front of the whole staff. That would be overwhelming to them. And so it's just better to avoid those days than it is to go Or we might teach other avoidant coping strategies. Okay, if you are in a meeting and you're afraid of being called on, I want you to picture yourself on a beach and feel the sand and breathe with 5 in and 4 out and all these things. And you'll be so focused on that if you are called on in the meeting, you won't even know what the question was, because you're going to be like, I'm on a beach right now and I have no idea what we're even talking about because I'm so focused on that. I need people in the world. I need people experiencing what's happening. And safety behaviors pull people out of the ability to experience things and therefore prevent people from learning how to handle things, because they only learn that I handled it because I avoided it. So avoidance, number one safety behavior to get rid of. Number two, reassurance seeking. Reassurance seeking is kind of like a drug. You build up a tolerance to it. The more reassurance you get, the more reassurance you want. And the more reassurance you get, the more you need as well, too, right? Because yesterday I got X inch reassurance, so today I need X plus one reassurance, because today I need a little bit more than I got yesterday. I used up all the luck from all of the reassurance I got yesterday. I still need it though, but I have to add a little bit more today in order to feel as good as I did yesterday about it. And what you'll find is that you're never going to be able to get enough reassurance over time, right? There's the problems we have can be insatiable in terms of the amount of reassurance that we want. The other piece is that if you tell me that I'll be fine and everything will be okay, and then I go do something and it turns out not to be fine and not to be okay, well, guess what? That's your fault. You lied to me. You told me everything would be fine or okay. It was not fine or okay. And therefore, something bad has happened. And it's all because of you. So this is why, again, I don't say to people, you'll be fine or everything will be okay. This is why I tell people that they can handle it, because I don't ever want someone coming back into a session and saying, you told me it was going to be okay, and I got horrible, terrible news. I don't want to be a liar to somebody. So I will not go down that route with folks. And I would encourage all of you not to as well. If reassurance was really helpful, then we could tell somebody something twice and that would be fine. Because assurance is telling them one time and reassurance is telling them more than one time. One of my favorite homework assignments that I give to families is, if you have a member of your family who is constantly asking the same questions over and over, and you're giving the same answers to them over and over, here's what I want you to do. I want you to get a notebook. I want you to put it on the dining room table. And if you're asked a question that you've already been asked and given an answer to, I want you to go to the notebook. I want you to write down the question. I want you to write down the answer. And going forward, if you're ever asked that question again, you say, oh, we did that one already. It's in the notebook. And that way, the person who's anxious can always go to the notebook and read it if they want to. Now, I will tell you this, they don't ever go to the notebook and read it. They already know what it says. They've memorized it. The reason they want to have the conversation over and over again is because there's such a high that one gets from reassurance. And also, there's a sneakiness to it too, which is, if I say some kind of reassurance today that's slightly different than the reassurance I gave yesterday, now that person's going to be like, wait a minute. Yesterday you said this, but today you said this. Have you changed your mind? Are you going in a different direction? Ooh, let's spend the next 98 hours talking about that. That would be great. Because guess what? Anxiety and OCD would love to talk about things ad nauseum. Number 3, distraction. Well, you can always make it look like you're doing a feared behavior, but you're not really doing it. These are the greatest distractors ever created in the history of the world right here, right? They're probably within a foot of each of us. And if you find yourself in the midst of chaos, hey, just turn on YouTube and watch kittens running through a field, because aren't they just adorable, those little kittens running through a field, right? I would contend that practicing breathing and muscle relaxation exercises in situations is also a distraction because you're focusing on that instead of learning how to handle the situation that you're in. Many people will fly, but be afraid to fly. If you're told you need to be in DC in 6 hours, you're going to go home. You're going to find that benzodiazepine that's in the back of your dresser, probably in a little baggie. And at this point, it's like powder. You're going to have to snort it if you're even going to get an effect from it. And then you're going to get to the airport. And what are you going to do? Oh, one second. I'm in here. Sorry. I'm at a hotel. Maid service tried to come by. What is going to happen is you're going to get to the airport and you're going to go to the bar and you're going to do a couple of shots. And then you're going to sit in the middle seat. And what happens on the middle seat, you can hold hands with people on either side of you because that feels really good. And then you can put a book in front of your eyes so you don't see the flames shooting around this steel tube of death you find yourself hurtling through the sky in. You can put on noise-canceling headphones so that you don't hear that announcement of Mayday, Mayday, we're going down. Even if you're an atheist, you might have brought a rosary or something with you to say all the prayers just in case. And when you land, you kiss the ground. And what do you learn? The only reason the plane didn't go down is because I did all of those things. That helped me, that kept me safe, that kept me distracted, that allowed me to get through the whole situation doing all of those things. And there's no way I could ever fly without doing those things. And I want you to fly. So if I'm working with you, the goal is this: get on a plane and fly and have none of these things available to you or even used whatsoever. If none of those work so far, substances are what a lot of people turn to. And there's not a lot of research on this, but there's enough that shows, like with OCD, about a third of people with OCD abuse substances at some point in time as a way to try to manage their intrusive thoughts, images, and urges. And so we have underreported the impact of substance use. And I'd contend even our graduate schools don't train us enough on this as well, too. I could have gone through all of graduate school without ever taking a substance class, because the notion back when I was in graduate school was, well, there's the mental health conditions, and then there's those substance use things. They treat themselves, that if you have a substance abuse, then you become a counselor for substance abuse. And so they do their thing, and then we do our thing. And I'm so angry about that we have that kind of thought, because there's people who are dying because of that, because we are not asking the right questions. We are not just two simple questions, right? Has anyone ever told you they were concerned about your use? Or have you ever tried to stop using and had trouble with that? If you could just throw those two very simple questions into any interview that you're doing, you could find out that maybe this person is actually using substances as a way to try to manage the anxiety and the discomfort that they're experiencing. So please always check for that. It's so important. I work with a woman named Margaret Sisson, whose son Riley died of an overdose. Riley was studying to be a therapist. Riley had OCD. Riley learned in high school that if you drink a lot, it shuts your brain off for a while. And so he started to abuse alcohol. Eventually, he went to a residential treatment center for OCD, but he got kicked out because he was trying to get into the nurse's room to get some benzos. So then he went to a substance abuse program, and he got kicked out because he was doing compulsions in his room and he couldn't get to the groups on time. And so here's a kid who wants help, and no one was treating both of the things at the same time. We were saying you got to be 90 days sober and all this. It's one of the reasons I opened the Foglia Center in Chicago, one of the first places in the world that treated both anxiety disorders and substance use at the same time. And finally, for OCD, we do compulsions, right? These are behaviors or mental acts that we do as a way to try to neutralize whatever it is that has popped into our head as an obsession. And remember this, you won't always see compulsions. And the reason you won't always see compulsions is some of them are mental. if someone has scrupulosity, which is OCD about religion, and they fear that if they say a prayer wrong, that they're going to go to hell, they may just be sitting there praying over and over and over again. But it might just look like they're just sitting there. So you won't always see a compulsion. And it is ultra important to assess for mental compulsions and not just focus on the physical ones. I'd contend that with safety-seeking behaviors, it's a short-term relief at a long-term cost, all right? What we do to feel good right now may not always be the best thing for us in the long term. So think for a moment about this. Imagine you have a niece or a nephew who are in a detox unit, right? And you go to visit them. And during your visit, they come over to you and they say, Aunt or Uncle so-and-so, this is the worst I have ever felt in my life. I feel like I'm dying. My skin is crawling off of me. I've got just sweats and diarrhea. I'm throwing up. My head is throbbing. I can't think well. Could you just go down the street? I know there's a liquor store down there. Could you please just go down the street, get me a couple of those small little airplane bottles of vodka and just sneak them in here so that I could stop feeling so terrible? Would any of you do that? Would any of you say, yeah, I can see how terrible this is and I feel horrible for you. Let's get you some alcohol. Now, hopefully you all said no. But if you did say no, then that means something that I think is very important, which is you're absolutely okay with somebody being physically uncomfortable now in order to be better later. And so what I would like to ask all of you is, are you also okay if people are emotionally uncomfortable now in order to be better later? And if you are, then you accept the ideas of what we're talking about in exposure and response prevention therapy. And if you're not okay with that, then you'll probably provide a lot of safety behaviors to people, and people then will just be stuck doing safety behaviors and believe that the way to get through life is to constantly do safety behaviors, right? I want people to try to get rid of as many of those safety behaviors as possible, and for them to learn, I can handle things, right? That's ultimately where we want to go. Can I handle it? Yeah, I believe that people can. Right? I don't have to like it, again, and it may not always be comfortable, but I can handle it. Now, that being said, safety in the sense of true safety, of physical health types of safety comes in. If somebody in a neighborhood that is very well known for violence and shootings and everything says, I'm really afraid to go outside at night, I will say to them, I think that's a great idea. Stay inside, right? I'm not going to put anybody in any risk whatsoever. That's not the goal. I'm just asking people to do things that everybody else does in day-to-day life, right? Most people drive without some kind of safety behavior. Most people walk down the street without some kind of safety behavior. Most people go to work without some kind of safety behavior. I'm just asking you to be like everybody else, right? You know, we in our health system put people through things that are uncomfortable so that they will eventually become comfortable, right? We put children with leukemia through chemotherapy, and those kids are uncomfortable. And yet, it's the chance that gives them the life that they could have post the leukemia, right? Long-term changes are difficult to work toward. They are uncomfortable. They don't have immediate gratification, right? Chemotherapy does not happen. I watched my wife go through chemo and radiation before she died, and it was hell, right? But it probably also gave her some extra years as well, too. So from an anxiety standpoint, anxiety prevention relies on short-term discomfort, being with a person, waiting that discomfort, that pain out until it really goes away on its own and we're not doing something to make it go away. And it allows people to learn there's really not a long-term negative effect of what they, and I use the word suffering purposely there because that's the word that one patient said to me one time, which I thought was funny. They're like, I'm suffering through this, but I know that it's going to get me there. And when they do that, they learn that they can handle things. So if we can really work on avoidance, reassurance seeking, compulsions, substance use, and distraction, and get those things really addressed, I'd contend that we would see huge changes in the way that people live their lives and face their day-to-day experiences, right? And also to recognize that sometimes we miss the safety behaviors. Sometimes people stay stuck because we don't check in on all of them. This is why when I'm doing therapy with people, I like to do it together if we can, do certain exposures together, even model some of those types of things for folks as well too, because I want to model for someone how to do a certain thing without doing a safety behavior while they're doing it. And that way, then they can see that it can be done. Or even a role play. A lot of times role plays will say to someone, all right, now you be you and I'll be the bully and react different to me this time. And I do role plays the opposite. I say, I'm going to be you, you be the bully, and I'm going to show you how to react to the bully with no safety behaviors whatsoever. So things like that we can do that gets people into it. And that's why I wanted to leave a good amount of time today for some discussion as well too, and some Q&A, because I know that sometimes when I introduce this to therapists at first, it feels uncomfortable for them as well too, because many therapy sessions are designed to, I hope you feel better when you leave than you did when you came in. And I would contend from an OCD or anxiety kind of standpoint that it's quite the opposite. I hope you feel like you ran a marathon after the session, because it means that we were facing fears, we were doing things that were uncomfortable, and you were ultimately learning that you could handle those things without having to do any kind of safety behaviors whatsoever. So a couple of ways that I've seen safety behaviors, and I'll just give you some of these examples here before we can open it up for some discussions. But number one, benzodiazepines. There's a significant problem with benzodiazepines in that they interfere with learning and they create something called state-dependent learning. So I did my senior thesis in college on social anxiety disorder treatment with placebo, benzodiazepines, or beta blockers. And we had someone come in and they would read in front of a group of people a passage from a magazine. And then they would take one of the pills. And they were blind to it. We were blind to it. Only one nurse knew what they were. She kept the blind. An hour later, after taking the pill, he would read another passage to people again, and then half an hour later, and then half an hour later, again and again. The next day, we would assess in the morning what their anxiety level was before reading the passage that morning. And what we found is that when people took the benzodiazepine, they got different results than when they took the placebo or the beta blocker. The people who took the placebo and the beta blocker had lower anxiety levels the next morning than they did the morning before. But when the benzo was taken, the anxiety level was the same as it was the day before, meaning state-dependent learning. What happened in those situations was they learned that they could handle the reading in an altered state. And when they weren't in that altered state the next morning, it didn't carry over, right? The placebo didn't do anything. The beta blocker was very minimal in the effect that they felt. So we didn't see state-dependent learning there. But in benzos, we do. So now, if there's a treatment going on and someone comes to me for therapy and they say, all right, I just took a benzo, I am ready to do exposure and response prevention therapy, I say to them, we're not going to do exposure and response prevention therapy now because you just took a benzo. I would be really irresponsible for doing ERP with you right after taking a benzo, because I know that I would be building you up for state-dependent learning. That's exactly what would happen, right? I've worked with people who will not exercise in order to keep their heart rate low out of a fear that their heart rate going up will lead to them having a cardiac event. But now, because of that, they're in such terrible shape, they've put themselves at a significant risk for a cardiac event. So this person had not done exercising for years. They were overweight. All they did was eat and sit on the couch and go to work and sit in a chair at work. There was no stairs taken, only elevators, minimal amounts of walking out of a fear of, I can't let that heart rate go up because it could cause me to have a heart attack. So our therapy was on the treadmill. We both walked on treadmills next to each other during sessions, or walked around a gym at the hospital that we were at. We purposely did everything that we could to get that heart rate up. And we had permission from doctors and everything. They gave the go ahead. Again, I'm not just going to say, I know what's best for you in this situation. That heart rates are out of my general purview of what I treat. But when I got the go ahead, I knew that that's what we had to do, because this person probably would have had significant health complications if they didn't start exercising. And so we had to work on getting them over the fear of exercising. And it wasn't, okay, let's do some muscle relaxation and diaphragmatic breathing beforehand. No, it was, today we're going to walk 100 feet. Tomorrow, 120 feet. The next day, 140 feet. And we added every day more and more things to this person doing stuff until they were walking for miles. And they were starting to see their weight go down and their joints were feeling better. And they consulted with someone for nutrition and they started eating better and they joined a gym. And over the course of a year, they dropped over 120 pounds. And they got a nice bill of health from their doctor. Not touching things to prevent people from getting ill, but still letting them touch your things. And if they get ill, that's on them. So I've seen this as well, too, where people are so afraid of the responsibility that if I, touch my mouth or pick my nose or something and I touch somewhere else and there was a germ there, and then another person touches that spot and then they rub their eye, they could get sick. And that would be my fault. But I'm absolutely okay if they go into my room, grab the laundry, touch my underwear and handkerchiefs and all these kinds of things and do the laundry. If they get sick from that, well, guess what? That's on them. That's not on me. That's just totally on them. And so there's this picking and choosing kind of experience that we see in anxiety and OCD as well, too, where as long as I'm not responsible for it, then it's okay. But if there's a chance that I might be responsible for it, I'm not really willing to take that chance. Not driving a car after a car accident is something that we see people doing as well, too, that avoidance. They may have driven for 40 years without an accident and been fine, but now one accident changes everything. It's interesting. It takes one time to learn to be scared of something. It takes multiple times to learn to be safe. So you can have multiple safe experiences and then a bad experience, and that one bad experience can kind of almost block the memory of all of the good experiences. If we're doing work with people, let's say they got stuck on an elevator, if I'm going to treat them for an elevator phobia, I'm going to work with them on an elevator. After a while, they'll learn, okay, this elevator is okay, but all the other ones are still bad. So Getting stuck on one elevator can make you afraid of every elevator in the world. Doing therapy on one elevator means that elevator is okay, but all the other ones are still bad. You have to start spreading people out to more and more elevators too. Again, it takes a long time to learn to be safe. It's very fast to learn to be afraid. Praying for the safety of people, in general, probably no one has an issue with that, unless that's taking hours and hours and hours of your day. I was working with somebody once who had an intrusive thought that if they thought something bad about their parents and they didn't say a prayer, their parents would die by the end of the day. And so we were working on decreasing the praying over time and getting them to not even say the prayer at all, so that they learn that just because they do or don't do that doesn't mean that it has an impact on the safety of their parents. I was willing to do that with them as well too. And I told them, for the rest of my career, I will have this card in my wallet, and it is still there. I will show it to you. Line 3 on there says, I hope my parents die tonight, please God. And then there's a 666 also down here at the bottom. The reason that I did that was I wanted to show somebody that thought action fusion does not occur. We can think something, we can write something, we can say something. It doesn't make it true, it doesn't make it real, and it doesn't cause it to happen. And he was willing to do something like that as well too. And of course, his parents were not killed because of that as well. My parents are still alive, by the way, 18 years after writing that card. One day that card will be correct, but I don't think the day my parents die that the card will be the reason for it. But that card will be right one day. And my parents know it's there, and they still say, hey, we're still alive. You haven't killed us with the card yet. So it's been kind of a family joke, actually. Walking through a doorway, maybe with a certain foot first, this idea that I have to do it this way, because if I do it the other way, bad things will happen. So I have to do it this way. If I inadvertently go through a doorway with that wrong foot, I've got to go back through, and then I've got to come back again with the right foot first. Because if I don't do that and something bad happens, that's the reason why. So getting people to do things the wrong way, the uncomfortable way, is so important. Sometimes a safety behavior is really subtle, even like saying, I'm sorry, right? There are people who, when you're working with them, will apologize a lot. Hey, sorry, just wanted to ask you a question. Sorry, just wanted to point something out, right? So I was working with somebody who did that all the time. And so we agreed that starting tomorrow, if you tell me you're sorry, I'm going to say to you, I do not accept your apology. And they did not like it, but they agreed that it needed to be done because this sorry thing was so out of hand. And other people in their life were also pointing it out to them as well, too. And so the next day he came in, and he was in our partial program, and he knocked on the door, and he said, sorry, I just had a question. And I said, before you ask the question, I just want you to know I do not accept your apology. And he stood there for an hour and a half begging me to accept the apology. And I kept saying, we agreed yesterday that I would not be accepting any more apologies from you, because we are working on breaking the habit of you apologizing when you don't need to apologize. After an hour and a half, he said, okay. And he went home. He came back the next day, walked up to me, shook my hand, and said, thank you. I really appreciate you doing that. I never thought that I would be able to get through that, but I did. And please make sure that the rest of the team also knows that if I say sorry, that they are not to accept the apology. So not a problem. We'll make that happen. And he eliminated, starting off pretty much every sentence that he said with, I'm sorry. And that worked out really nice. You'll also hear little other subtle things. Yeah, this will be the last time, but could you just tell me one more time, or something like that, where we make false promises all the time as well too. I really don't need you to do it ever again, other than this time, which is, again, these are lies, not malicious lies, not intentional, but they're out of desperation lies. Like, I just feel like I can't handle this, and I need one more thing from you. There comes a point where you're going to have to learn how to handle it. And again, that's when we get to the point of the elimination of the safety behavior. And that becomes our goal. So what I want to do now is I'll stop sharing there, and I wanted to open it up and take a look at some of the chats and the questions and things that came up as well too. Yes, I will be happy to share the PowerPoint also, Christy, not a problem. Happy to
Perfect,
do that
thank
with
you.
everyone. So I could do that. And yeah, there we go. So let's see what we have first. Copy of the slides. Yes, we could totally do that. Let's see. Is it safe to say therapists who use safety behaviors like coping strategies are stopping their clients from healing from the experience? Here's what I think. If somebody has to have a coping strategy to get through something the first few times, then okay. But then let's work on eliminating the coping strategy toward the end so that they don't have to keep using the coping strategy. I say this because sometimes we find ourselves in situations where things just happen in the world, where there are surprises that occur, and we don't always have the option or the luxury of being able to do all of the things that our therapists have told us to do to get ready for a situation, to be prepared for it. And if that happens and there's a surprise that occurs and we didn't get to do all the coping strategies or have everything with us, should we run away from the experience? Or should we know how to handle that as well too? And I would contend I'd like you to know how to handle that. So I do work on wanting to eliminate as many of those things as possible so that when things happen in the world, because they do happen, right? And so that when those things happen in the world, that we face our fears. You know, our main office is in downtown Chicago for NOCD. And so a couple of years ago, I was driving to work. I was in downtown, and somebody cut me off, and they rubbed the front of my car when they cut me off. And so they kept driving. So I went around the side of them at a stoplight and I said, "Hey, you hit my car. I need your info. I got to report this." And they pulled a gun on me. And the light turned green and they drove off. And I kept driving too. And I wanted to at least get the license plate. Probably a dumb idea in retrospect, but a lot of things going in my life. I had some anger going on at that point. My wife was dying, and there was a lot of bad stuff going on. so it's like, yes, in retrospect, I should have just stayed there. But so I'm driving, following this person, trying to get the license plate. They go around the corner, right where Pizzeria Uno is downtown there. And I come around the corner, and they're outside of their car, and they take a shot at me as I come around the corner. It's a rough day, obviously. It's not very fun. I approached it very nerdily. Over the course of the next 3 days, I experienced every symptom of acute stress disorder, but I was like fascinated at the same time. It was like, oh, there's that one kind of thing. Whenever the next one would occur, and I made sure that night, though, when I drove home, I drove through that same intersection again. And then I drive through that spot every single time I go downtown now, purposely, because I'm not going to let that experience stop me from driving down that street. I'm not going to avoid it. I don't have to be on the phone with anyone while I'm doing it. I do not distract myself while doing it. I put myself purposely into that situation so that I learn and I keep teaching myself that I can absolutely handle that experience. So to me, that's kind of just important kind of stuff, right? So some of the Q&A questions, defining safety behaviors. I would contend, talked about this a little, but anything that we do that kind of pulls us out of fully engaging in the experience that we need to learn how to handle could be a safety behavior, right? And so I want people facing those fears and learning that he can handle those things. Let's see this one. I work in a forensic hospital. The individual I'm working with is anxious about thoughts to harm friends or family, has a diagnosis of OCD, is here after he stabbed his mother. Prior to this, he carried a knife at school for a week because he thought he wanted to stab a peer who was bullying a friend. He also had thoughts to harm his friend, and he wanted to protect. The thoughts were distressing him, and he disclosed this to his friend because he wanted to commit suicide and was hospitalized. This happened a year before he stabbed his mother. Would you change your recommendations based on this since he acted on your thoughts, on the thoughts? Yeah. You can have OCD and still do these types of things, right? I wouldn't contend that this would be a person who has harm OCD kinds of fears. It would be interesting to learn more about the case, actually. But when you're doing some of this kind of stuff, what I want to do first is take a look at what is the fear, right? So if he has a fear that he might stab someone, but then he's taking a knife to school on his own, that would be a little odd to see, right? Versus work, because most of the time, and I will say this in 25 years of treating this, if somebody comes in to my office and they talk about a fear of harming people, they're spending hours checking themselves to make sure there are no knives on their body or in their clothes, and they don't think they've done it enough, so they keep checking their pockets over and over and over again to look to see if there's a weapon on them or something of that nature. So the fact that this person was carrying weapons with them, I would think maybe there was, as you say, he has a diagnosis of OCD, but I think there's some other things potentially going on in that case as well too. Once in a while, people will call me and say, I have OCD and I have fears that I will harm myself or others. And so I test that out. One person who had called, I don't know who they were, I never got a name. It was the mother of someone who just said, my daughter was afraid that she might do something to harm herself, so she wanted to test herself to see how close she would get it. And so she turned on a Vitamix and she stuck her finger in it to see how close she could get it to the blade, but she got it too close and the Vitamix ripped one of her fingers off. I consulted with everyone I know in the OCD community, and no one was interested in taking that case as an OCD case because that's just not where you typically see people with OCD go. So I contend in this situation, something else probably going on, and I don't think that any of that stuff about the knives was probably OCD. Let's see. So how does this apply in a school setting? One of the things that you typically see in schools and school anxiety and school refusal, and I did a lot of work on that. I opened the school anxiety program over at Alexian Brothers. I don't mind, again, 504 plans or IEP plans, as long as those plans have things built into them that the accommodations will decrease over time versus increase over time. And the reason that I want to see the accommodations decrease over time is that I want to prepare people for life outside of school. Because life outside of school doesn't come with a 504 or an IEP plan. Life outside of school doesn't, provide all these accommodations to people. If you have the choice of hiring two people, one who says, I'll be here whenever you need me to do the work that needs to be done, and the other who says, I'll need to take a nap every afternoon in order to be able to function every day. And I'd like to have my mom or dad with me at work every day too, because they are really my biggest supports and they help me every day whenever anything goes rough, and they rub my back and they tell me that I'm great. Who are you going to hire, right? Which is the person that you want to bring into your job. So I want to work on eliminating some of these things over the course of time so that by the time people do leave school, they're really prepared for living in the world that isn't going to be as accommodating as school was. So that's what I think is really most important. And I would hope strategies at schools would be working toward that. Now, I get that sometimes that's tough too, because sometimes we're dealing with parents who say, but my child should never feel anxious. There should be no anxiety that they ever feel whatsoever. And that's really unfortunate, because I think that in those situations, we're sadly setting kids up for failure if we're telling them that they shouldn't have any of those types of things. We want people to learn that they can be uncomfortable, to learn that they can be anxious, to learn that they can handle things that they don't necessarily like handling. It's not about eliminating the possibility of all of those things from happening in everybody's life, right? If that's the case, all of us just live alone in a panic room, and that way we'll never know if somebody's been hurt. We'll never know if somebody's died. We'll just only be pumped good news and nice music and everything, and we'll be given everything to us without ever having to have any kind of adversity whatsoever. The world just doesn't work that way, right? And so how do we thicken people's skin up to be able to handle what's going to happen in life, right? You know, when I got married, no one told me a year later that my wife would get diagnosed with a terminal illness and that I'd become a caregiver for the next 6 years. And I didn't need to be provided all sorts of safety behaviors. I consulted people. I took the best answers. I tried to apply them to day-to-day life, right? And go into those types of situations knowing that it's okay not to have every answer. It's okay not to know everything in this situation. I'm going to learn as I go. And I'm not going to set myself up for failure by thinking, okay, I have to do this perfectly. Some of that comes in here too. What are the cognitive distortions that people are holding on to that lead them to want to do stuff that has to be perfect, where they're not allowed to make a mistake? Everything has to be just right as well too. Those things will have to be addressed as well. Curious on your thoughts about inference-based CBT for OCD. Use ERP and you've learned ICBT. You're finding it effective with clients so far. I haven't done any training really on it, Carol, so I can't really comment on it. So I'm just not aware of it enough yet. I know that I know some people who are doing some training and they've offered to have me go through it. So I will take a look at some of that, but I don't have anything to comment on it at the moment, at least. When doing ERP and acknowledging that people with anxiety and OCD can talk about things constantly, what are you discussing during the therapy session? Well, I'm trying not to discuss anything that we've discussed already, right? If there's something that we've had a conversation about, I don't want to be repeating conversations because that would be reassurance, and that's not where I want to go. And so in sessions, I'm not as much talking about things as we're doing ERP right there in sessions. And if the person wants to talk a lot during ERP, I will be very silent, other than to remind them that I believe that they're talking while they're doing the ERP is potentially distracting them from the ERP itself. And instead of distracting from it, I would like them to just really focus on the ERP exercises and stay in the moment with them instead of trying to talk to me, because I will not be a part of the distraction from it. So I think that that's really, really important to remind people to stay in the moment and to stay so focused on that. Mary says, I would in schools and OTs often use safety behaviors to help students cope with issues like being afraid in an assembly might be too loud, the lunchroom is too chaotic, etc. How do we reconcile what is an emotional mental health issue or a sensory issue? Great question, Mary. And I think even in sensory issues, if we can work to gradually get people back into those situations, maybe some recordings of the lunchroom first and then playing them very low level and having the person listen to them on some earphones, and gradually over time turning that volume up until it equals the volume of the lunchroom, and then maybe going into the lunchroom and just walking through it, and the next day staying in it for 30 seconds, and the next day 40 seconds, and the next day 50 seconds, and gradually building up to those types of things so that people allow themselves to get used to that experience. I say this again because, I don't know what school will be like in the future, college if they're going to go, a workplace that they have. Maybe their job in the future will have assemblies or something like that. Are they going to call off for all of those experiences, or are they going to learn how to handle some of those? So I think that we can definitely do ERP experiences even to some of these sensory issues as well too. One kid that I had worked with hated school assemblies because they would use the scoreboard sometime, and the scoreboard had the buzzer on it, and the buzzer would go off sometimes during the assemblies or games if they were playing in the gym, and then he didn't want to go to gym anymore. And so the school let us go in over the weekend and we got to play in the gym, and I got to let him do the scoreboard. He got to hit the button himself first and practice it and see that, all right, when he was doing it, it wasn't so bad. And then I had him stand next to me and he got to see me when I was pressing it, and that wasn't so bad because he could see it. And then I had him move further away. And after about 2.5 hours, he was playing basketball with his dad and his brother. And I would randomly just hit the buzzer while they were playing, and he wouldn't be bothered by it after a while. So we did nice ERP to that experience and built up to him not being so bothered by the sounds of that. Thoughts about fidget type items being used in school, which are supplied by the counselors. So again, maybe for a little while, but can we work on eliminating some of those things as well too? Now, the other piece is, what's the diagnosis, right? If it's someone with ADHD and they're using it and they're actually able, by doing that, to stay focused and pay more attention in class, that's different than somebody who's anxious, who's doing that and focusing on that and not paying to anything else in the attention to anything else in the class whatsoever, because this is their distraction tool. So I think that instead of a one size fits all kind of experience in that answer there, I really want to know what's the purpose of it and what is it serving and what would happen if it wasn't there. If the kid wasn't able to use it and therefore they wouldn't even go to class, I know it's an anxiety issue. So now I'm going to work on some ERP to get that kid into class. If the kid isn't able to use it and they'll stay in class, but they're bouncing off the walls and they're not paying attention, but when they are using it, they're paying attention, they're sitting in their seat, I'm okay with that then, right? So I just want to know some of the context in that type of situation, because in that situation, it might be more helpful than anything else. If there's time, could you speak to your process of working with people with autism or ADHD who have accommodations for school or work? Well, we just did a little bit of that, but yeah, I understand the need to decrease accommodation related to anxiety, safety behaviors, but how do you work around accommodations that are in place because ERP wouldn't be effective? I'm thinking how damaging ABA type interventions could be for some folks. Thank you. So one of the things that I think is important is, again, even on going to the autism spectrum, we know that people on the autism spectrum really do like to have set routines, ways that they do things. Maybe they go to class the same way every day. Maybe they are on the same bus. It's the same bus driver. And on days that the driver's different or the route has to change or there's a hallway that's had a spill in it so the kid can't walk down that hallway to get to their class, could be really, really difficult experiences for them. So what I would suggest in those situations is any counselor working with someone who has some of those concerns purposely practice some of those things. Like, I know that normally we go down this hallway between fifth and sixth period, but sometimes in that hallway, people maybe throw up or spill something, or there's going to be some construction going on in this part of the school in the next couple of months. I'd like to practice taking a few other routes with you so that on the days that you won't be able to do that, it won't be so troubling to you because you'll have learned other ways to do it as well too. So I think that if you get a chance to do that, that's really, really helpful and really preemptive. I love using peers in these situations as well too, if we can. One of my buddies is a school counselor, and one of the things that they will do in the school counseling is they will do this thing that they call a investigator group. And what they do in the investigator group is they watch the kids at recess through little slats in the blinds, and they take notes, right? And these are all kids who are either on the spectrum or have a lot of social anxiety. And then they role play how to do interactions with each other right there in the room that they're in. And then eventually they send one kid out a day to the recess, and all the kids stay in the room and watch through the one open slat in the blind. And they take notes about the kid who went out that day. And then they give that kid feedback about how they did while they were out there at recess with everybody else, right? So even something like that is really fun for people to do. And those kids really love it and they learn a lot but they're learning in an environment that feels safe for them because they're with people who are like them and understand them very well. And that can also be very, very helpful too. Do I have recommendations for more in-depth ERP training? Yes, absolutely. There's a couple of things. The International OCD Foundation does something called the Behavior Therapy Training Institute, the BTTI. That's something that is a weekend-long behavior therapy training focused specifically on ERP for OCD. At NOCD, we have something called NOCD Academy. We do free continuing education work through NOCD Academy, and you can go there and do live and also at-home courses. And there's a lot around exposure and response prevention therapy for anxiety and OCD and other conditions as well too. So hopefully those would be helpful for you as well. Let's see, we got another question on the chat. Question about preventing safety behaviors before they start. I work in a residential recovery house and will have clients who have used substances for years, decades even, as their safety behavior and their everything, right? And now they're fearful about general living without their substance. What's a good starting point to suggest for them if they feel they need something outside of substances, such as breathing exercises, imagery? Apologies. No apologies needed. Good question. So again, if somebody seems like they're not going to do something without something else to do that, I'm not going to necessarily say you can't do it at all, right? But what I will potentially say is, okay, if you want for the first 5 times you go do this to do some breathing exercises while you're doing it, okay. But then by time 6, let's work on cutting that in half. And by 7, half again. And maybe by time 8, we're not doing them at all. Right? Because again, the world will throw surprises at you, and you won't be able to always just start doing diaphragmatic breathing and muscle relaxation in a crowd of people or something like that. It might seem a little awkward in some situations. So again, my goal is always going to be, can you live in a world and function the way that people who aren't doing safety behaviors, can you function in the same way that they are as well too? And I believe that people can. And I want to empower people to really know that they have the ability to do that they have the strength to do that, they have the fortitude to do that, they can go out and they can handle life the way most other people do. And they don't have to listen to the incessant, tape going on in the back of their head of obsessions and doubts and uncertainties. And they don't have to believe those things. And they can be in the world the way that other people are too. So that's always the goal that I have for folks to be able to do it. If we can eventually get people to face the world the way most others do without all the safety behaviors, the confidence they have increases significantly in being able to handle anything in life. And if I can help people increase that confidence, I'm going to do that every day that I can. So what do you think, Christy? How are we doing?
Yeah, that was amazing. Yeah, what a great, fascinating topic. A lot of amazing, questions and interactions. So a lot of positive feedback for you, Dr. McGrath, and thank you so much on providing those resources too. Maybe if you, I can if you want to shoot those in the chat, I can share those as well. One was your website, and the other one was it BTTI?
Yeah, through the International OCD Foundation. So if you go to the International OCD Foundation, you'll see something about the Behavior Therapy Training Institute. Mm-hmm.
Okay, perfect. Well, thank you so much. And I'm just going to share my screen for a second here. Just give my contact information. Appreciate you all attending on this Friday before the long weekend. I hope you all have some fun activities planned. So thank you again. And we are going to take a pause on this series this summer, and then we will be back in the fall. And if any of you have any topics of interest or ideas for CE presentations, feel free to reach out to me directly, and we will definitely take those into consideration for the fall series. All right. Anything else, Dr. McGrath?
No, thank you all so much. And thank you, Suncloud, for setting this up. Really appreciate it.
Thank you. Thank you for your time.